Thank you very much, Maria, and thank you very much for the invitation. I just would like to address some of the topics that were discussed later. So let me start by where we were in 2006 with intra-arterial chemotherapy. I think we had, for that time, we had promising initial results. In 2006 was the time when the Memorial Sloan Kettering started. Our group in Barcelona started in 2008. There was just a single center experience with this super selective catheterization of ophthalmic artery. Melphalan was the only drug used for that time. That was called, as Shahar mentioned, super selective catheterization, but I agree that it is not the right term. It is not exactly super selective. It is more selective than the previous one, but probably still not super selective. There were no animal data available. We weren't from the clinic to the basic. The other way around we do in pediatric oncology. And there were, as mentioned by the previous speakers, many concerns of ocular toxicity in this population. And also there was some concern of potential higher risk of metastasis because some groups felt that the systemic exposure that this patient get because of the super selective catheterization would not be enough to prevent systemic metastasis. There were also concerns that without using systemic chemotherapy, from switching to systemic to intraarterial, we would see in the future more cases of trilateral retinoblastoma. But what happened? Sorry, what happened later? What is the situation now in 2021? Intraarterial chemotherapy is used in more than 50 countries, and there were thousands of patients treated. In fact, in my center, I also work in Argentina. In my center now, we are reaching the 2,000 infusions in our own center. We don't treat one eye, we just treat two eyes, and we treat two eyes in the same session, which is called the tandem infusions. Many of us use multiple drug regimens for many years, using melphalan, topotecan, carboplatin, in one eye, in the other eye, depending on which treatment which patient we use. The ocular toxicity is seen, it can be severe, but we found it severe in less than 3 or 4% of all the eyes we treat. We finally came up with animal pharmacology data. So now we know that, as Shahar mentioned, this is not super selective. It is going to the systemic circulation, but in much less amount that you see in systemic chemotherapy, of course. Most of us did not find that there is an increased risk of metastatic disease, but here I would stress what Livia has mentioned, that it will also depend, it will heavily depend on the patient you choose to treat with intraarterial chemotherapy. So you still see some cases with metastatic relapse, as you see with enucleation, as you saw with intravenous chemotherapy, but it will also depend on the patients you decide to treat. We did not see any increase of trilateral retinoblastoma over these years. And what I think has been most important in improving the results of intraarterial chemotherapy and probably pushing the rest of the groups with the balance to use intraarterial chemotherapy was that when you associate it with intravitreous chemotherapy for the treatment of the vitreous seeding, the results are really, really outstanding. A few words about the pharmacokinetics of intraarterial chemotherapy that we published in my group in Argentina by Paula Shajkevich. We found that when you compare intraarterial chemotherapy to intravenous chemotherapy with topotecan, which is a drug that can be used systemically, not only the amount of the drug the vitreous gets is significantly higher, as you might expect. Not only the retina gets more chemotherapy, but very importantly, the optic nerve gets much more chemotherapy than when you give chemotherapy intraarterially compared to intravenously. So you see here that the median concentration of topotecan when you give intravenously is around 10 nanograms per gram of tissue, which doesn't make too much sense, but it makes sense when you see the mean concentration after intraarterial chemotherapy is around 2,000. So it goes from 20 to 2,000, the concentration of the chemotherapy in the optic nerve that these eyes get. And why this is so important? Because the optic nerve is the major route of dissemination of retinoblastoma. From the optic nerve is where retinoblastoma gets into the CNS. So that is extremely important because you are treating the major site of dissemination of retinoblastoma with higher concentration, the highest concentration of chemotherapy you could get. So you would expect, as it really happened, that the cases of CNS dissemination after intraarterial chemotherapy are very few. There were reported a few cases with systemic metastasis after intraarterial chemotherapy, but the optic nerve is very effectively treated. As we say, as pediatric oncology, as pediatric oncologists, it's like you are giving a bone marrow transplantation to the optic nerve at every cycle. It's a very high dose, massive dose of chemotherapy to the optic nerve. So where are we going now? Last week, we had a meeting in the Latin American group of pediatric oncology, and there were three treatment groups, two in Brazil and one in Argentina, that we are using intraarterial chemotherapy for orbital retinoblastoma. We are designing a protocol with intraarterial chemotherapy, systemic chemotherapy, and intrathecal chemotherapy for the treatment of not only orbital retinoblastoma, but also chiasmatic invasion of retinoblastoma. This is a case we published last year in Pediatric Blood and Cancer, and there are two more cases from Brazil that are getting cured. Hopefully, they are with about 2 years follow-up, and the response we see is really incredible, targeting the orbit and targeting the prechiasmatic lesions. So we are quite enthusiastic because we are, on one hand, looking for eliminating radiotherapy for the orbital retinoblastoma, and on the other hand, curing perhaps some of the cases with prechiasmatic lesions of retinoblastoma, which were previously uncurable, even with bone marrow transplantation. So here, I think this is what has been mentioned before. Patient selection is really important. If you give intraarterial chemotherapy here, it is one thing because the risk of dissemination is very low, but if you give it here, it's higher. If you give it here, it is probably prohibited. And we also still enucleate most cases with unilateral advanced retinoblastoma because the survival results are really excellent. There is really no major advantage in preserving those eyes functionally. And we are sure that we are going to get a 98, 99% survival rate in those cases. So that brings me to a concept that was introduced by Francis Munier, which is about the state of metastatic grace, because what happens when we treat and treat and treat conservatively these patients? When should we say that's enough? Because we have so many tools now. We have the intraarterial, we have the intravitreal, we have the intracameral, we have the plaque, we have the intravenous, we have a lot of treatments these patients get, sometimes 12, 15 applications of intraarterial chemotherapy because they are fighting for the only remaining eye. And what is the risk of extraocular relapse? It is the same in every patient. So this year, we published a very interesting paper with international collaboration between Barcelona, Argentina, Memorial Sloan Kettering, and the Curie Institute, where we found that in cases that have been secondary enucleated, so they failed systemic intraarterial whatever treatments they received, they have a genomic profile which is different. They show like new for retinoblastoma, but well known for pediatric oncologists, because the pediatric oncologist in the audience will know about 11q deletion that is seen in neuroblastoma. They will know about problems in chromosome 1q. So we think that this is probably a molecular characterization of a newer subtype of retinoblastoma with 11q deletion, which can be resistant to intraarterial or systemic chemotherapy. These subclones will be resistant to this conservative treatment. So we are trying to depict, as we are doing in other tumors, molecularly the different subtypes of retinoblastoma. So let me talk a bit more about the non-chemotherapy treatment. This is a publication we did last year about treatment of MECAN amplified metastatic retinoblastoma. A very few cases with MECAN amplification of retinoblastoma has been published. And we found, this is a paper reporting 2 cases. This is extremely uncommon. One of the cases was treated in India, the other one in Argentina. These are chemorefractory tumors. So what we did was a genomic analysis first to identify they were really MECAN amplified retinoblastoma. Then we generate animal models from these cases, and we did high throughput screening of about there are thousands of drugs that we screened, and we found that the combination of panovinostat and bortezomib was the most relevant and most active combination for these cases. Also, that's why I talk about non-chemotherapy treatment. All the retinoblastoma cases express GD2, the ganglioside GD2, and also MECAN amplified retinoblastoma. So they are now, this is a target for immunotherapy, that we have now a drug targeting, more than one drug, in fact, targeting GD2. These are monoclonal antibodies against GD2, as we show here in the picture in green. Retinoblastoma expresses GD2 very, very intensively. So this is a study that was published this year using CAR T cells directed to GD2. These CAR T cells were embedded into a gel, an hydrogel that was injected intravitreously. And you see here in this animal model how well these CAR T cells, this is only treatment with CAR T cells, they did a great job in controlling the tumor when it given intravitreally. So this is the results of our group in Barcelona, where we developed an oncolytic virus. It is easier now to explain what is an oncolytic virus. Now with the COVID times, we all know about adenovirus that are modified to target something different. That is what we did in Barcelona. This is an adenovirus, a simple adenovirus 5, where our group made a genetic modification of the virus. So when the virus enters a cell, it can only be replicated when it finds the E2F factor released from the retinoblastoma protein. That only happens if you have a mutation of the retinoblastoma protein. In normal cells, they are both together, so the virus cannot replicate. When you have retinoblastoma or other tumors with dysfunctional retinoblastoma protein, it is released from the E2F. So the virus can replicate and cause a lysis to the tumor cells. That was published by our group in Barcelona in Science Translational Medicine 2 years ago. So you see here the preclinical work. This eye of the mice, of this mouse, was injected with the virus, and had the tumor, and this eye had the tumor and has not been injected with the virus. You see here after 3 weeks the difference in the results. You see here also in the Kaplan-Meier curve comparing the virus a control, comparing melphalan, and comparing the standard of care chemotherapy. I have to say that these cells came from our patients that had relapse disease. Probably they have chemo-resistant disease. So even in chemo-resistant cases, our virus is still active in actually curing the mice with retinoblastoma, with the only treatment of the virus. So you see here, when we see the metastasis in cases treated with a vehicle, you see here that about 44% of the mice had CNS metastatic disease compared to none treated with the virus, compared to 16% of treated with melphalan, and compared with 45%, exactly the same rate of the vehicle. But you must remember that these were chemo-refractory tumors. So we went ahead and we reached to the patients. So we have now a phase 1 study, which is going on in Barcelona with this virus, this injected intravitreally, this VCN01 virus that we are using for relapse and refractory eyes. You see here in the picture below, one of the cases that we treated, you see these cases were going for enucleation. You see here, this is how the patient arrived to us. This is after the first dose. This is after the second dose. You see, we found a very nice response in the vitreous. This is how the protocol looks like. We are giving 2 intravitreous injection of the VCN01 virus. We collect specimens in the body to check if the virus is not disseminating, is not replicating in the body. I have to tell you, but the 5 patients we treated so far, it is not. And this is the registration of the study. Let me show you a couple of more cases. This is the one that we showed in the paper. This is the most recent case, positive case we had. This child came from South America after failing everything. Intra-arterial, intravenous, intravitreous chemotherapy. Had the other eye was enucleated. This was the only remaining eye, very little vision. You see here how the patient came. This is here after the first injection. You see how well the vitreous seeding responded. You are ophthalmologists, most of you in the audience, you will also tell me, but the vitreous looks hazy. Yes, we see a vitreitis in most of the patients. We were scared at the beginning because we didn't know, we did not see that in animals. We now are much confident in how to modulate this response. We think this is the immune response to the virus that we are seeing. We see it more often as the patient, as the tumor burden is greater, we have more immune reaction. You see here after the second injection, then we decided to give a 3rd dose to this patient. And this is how the tumor looked like after 3 doses. You see here compared with this one. This is how the child came. This is only with the virus treatment. So the response was really outstanding, but it was still not enough. The patient was now off protocol. We gave 2 more cycles of intra-arterial chemotherapy, a couple of intravitreal chemotherapy with topotecan, and we consolidated with the brachytherapy. And the child, this is how the child looks like today. And it was in a couple of months ago. So we could say that there are some myths that are really not, that retinoblastoma has little else than RB1 mutation. We found that there's new other molecular alteration. So there is not, it is a great work being done at Curie Institute that is not, the retinoblastoma is not a uniform tumors. There are molecular subtypes. We hope the paper is going to be published this month. And also what I learned in medical school, that the eye has no immune system. It is, CAR T cells work, virus work. We see immune reaction to the treatment we get. So I still, this is an oversimplification, of course, but I think that immunotherapy, as in other pediatric malignancies, could have a role in retinoblastoma. So more conclusions, these are quite long, and in the interest of time, I would not go over in them. This is more related to the virus. I'd like to thank you for your attention, and I would be happy to take questions if there are any. Thank you very much. This is thank you in Catalan.